Hello, my name is Bogdan Nazar, and this is my thesis, Continual Learning in the Medical Domain, Applying Rehearsal Methods for the Classification of the Diabetic Retinopathy Pathology. This is the table of contents, I'll get right to it. Introduction. AI methods are increasingly being used in computer-aided diagnosis, in large part due to increases in data generation and better models. The medical field has some unique restriction regarding data privacy laws, which make it difficult to collect and store large data sets. Most machine learnings are static, but continual learning keeps learning from a continual stream of data. It requires less data to be stored, and it's continuously up to date. Diabetic retinopathy is a very impactful disease worldwide. Diagnosis can be aided by ML methods, and there is no literature on continual learning methods applied for DR, which is an opportunity for research. Review. Worldwide prevalence of diabetes is more than 8%. Diabetic retinopathy is a complication of diabetes where high blood sugar and leads to inflammation and damage to the retinal blood vessels and optic nerves. This leads to impaired vision. It affects 1/3 of diabetic patients, and it's the leading cause of blindness in the world. It is evaluated with an ophthalmoscope device, and diagnosis is based on the retinal fundus images. It is classified into the following stages: mild, moderate, and severe non-proliferative retinopathy, with several findings, and the most severe proliferative diabetic retinopathy, where abnormal blood vessels start proliferate, which then bleed and leads to further vision loss. There's a problem in that the physician is gold standard, but there's a high integrator variability. That means that an automatic system for identification and assessment is potentially valuable. The evaluation metric used was Cohen's quadratic kappa, which, unlike accuracy, measures the degree of agreement. It is more relevant for DR because labels are can be considered continuous. Kappa score is goes from -1 to 1, complete disagreement to complete agreement, and on top of this, the quadratic kappa has the following formula, and it has a weight matrix that penalizes disagreements that are further apart. Machine learning methods for DR detection, they can be seen from the 90s with matching for vascular structures, then handcrafted features for multiple structures identification, and then statistical methods used to generate predictions. From 2014, we had neural nets. Um, in 2015, there was a classification challenge organized by Kaggle, which also offered a very large labeled diabetic retinopathy data set. And from 2018 to now, a lot of models having neural nets and many neural nets with ensembles and increasingly improving results. Uh, Definition of continual learning: it's the ability to incrementally learn new knowledge while retaining previously learned experiences. The advantages are adaptability and memory efficiency. The main disadvantage is catastrophic forgetting, where training a model with new information slowly overrides the parameters it was trained on with the previous data. This can lead to degradation or complete loss of previous data performance. Addressing catastrophic forgetting, we need to check 3 points: plasticity, stability. Plasticity is refining old knowledge and acquiring new knowledge. Stability is preventing novel input from interfering with existing knowledge. This is stability plasticity dilemma. And also resource use, as most solutions require either more computation or memory and must be optimized as well. There are three main approaches for tackling catastrophic forgetting: neural net methods, expansion methods, replay methods. Baseline naive fine tuning model just continues to be fine tuned on a continuous stream of data. Regularization prevents forgetting by introducing certain constraints on the updating of neural weights. Sparsity ensures just a subset of parameters being active for one task at a time. Expansion increases the model's capacity, such as adding new neurons or when a new task is encountered. Replay methods periodically retrain a model with old data in order to prevent forgetting. Here we have rehearsal, replay with real data, or pseudo-rehearsal, replay with synthetic data that was generated from past data distributions. The rehearsal strategies applied in this thesis were cumulative replay. At each epoch, the model is trained with all data accumulated up until that point, and free sampling strategies, where only small samples are kept in memory and a memory buffer from past data sets. We have random sampling that approximates the original data distribution, error-based sampling, and uncertainty-based sampling. In the medical domain, we've seen applications for segmenting brain MRI images, detection of chest X-ray findings, and cardiac and lung nodule segmentation. However, while more flexible, they yielded lower final performance when compared to static scenarios, and there were no documented attempts for continual learning for diabetic retinopathy. This makes it harder to compare results, but also an opportunity for novel research. Materials and methods. Objectives. I formulated as a classification problem, also applied the Cypher 10 classification task in conjunction with DR for an additional benchmark. The objectives were explore performance of a CNN model in a static setting for diabetic retinopathy, explore different replay strategies for continual learning, evaluate findings and compare performance of static and continual models, and discuss viability of deploying such model for clinical setting. Dataset. 2015 diabetic retinopathy, 88,000 high-resolution images, 35,000 labeled, 53,000 unlabeled, large size, 90 gigabytes of data. 5 classes, no diabetic retinopathy, mild, moderate, and severe, and also proliferative, and this is the distribution of labels. During training, we evaluated it with quadratic kappa, accuracy, and loss. For the final evaluation, many more common metrics were used, also for each class. And for the diabetic retinopathy class, binary classification metrics are also computed. Experiments. They are performed for 200 epochs for Cypher 10, 100 epochs for diabetic retinopathy. Dataset was pre-split randomly into 80% training data, 20% validation data. 6 static learning experiments with 80% down to 4% of the data. 5 continual learning experiments. These were naive fine-tuning, 24% subsets, cumulative replay, 20 subsets of accumulating data, and 3 replay with 10% memory buffer. These were random sampling, error-based sampling, and 3 model ensemble uncertainty-based sampling. Cypher 10, pre-processing. No pre-processing for Cypher 10. For diabetic retinopathy, I removed variation between images due to differences in lighting conditions, resolution, and acquisition techniques. Images were rescaled to the same radius. Local average was subtracted to remove lighting conditions, and margins were clipped to remove optical boundary effects and artifacts. This is how the dataset looks after cropping all the images to 510 by 510 pixels. Model was efficient net B1 from the family of convolutional efficient net B convolutional nets. I chose it because it's very flexible, it's very efficient, it's 7 times smaller and 5 times faster than ResNet, and achieved better accuracy on ImageNet, so I could compute it on my own GPU. I used the implementation from Hugging Face TIM library in PyTorch and Python 3. These were some of my scripts. Model architecture. It used the convolutional and mobile inverted bottleneck layers, also polling and fully connected layer at the end. And B1 is a slightly upscaled version from this. I made a diagram of it on the right side. Training process for 200 and 100 epochs respectively on 2 different GPUs, cross entropy and loss and atom optimizer. Average training time per epoch 10 seconds to 2 minutes for Cypher 10, 2 minutes to 19 minutes for DR. Validation 5th 20% split of the training set, and final testing was on a separate dataset, the separate test set for Cypher 10, and the validation set for diabetic retinopathy, as I didn't have another one. But final Q kappa was computed on a private test set. Results. I emphasized accuracy on CIFAR-10, quadratic kappa, and diabetic retinopathy. Due to computational constraints, I could only perform limited validation with performing the experiments twice and averaging over the results. For the CIFAR-10 static experiment with 80% of the data, stable learning curves, highest validation accuracy 92%, test accuracy 91%. State of the art is much higher, but this was considered sufficient as a higher benchmark. All classes scored balanced F1 scores, and only classes 3 and 5 exhibited some confusion between them. For diabetic retinopathy, the curves have a little more instability. Highest Q kappa 0.8. State of the art is around 84, 92, depending on the data set. Global metrics were highly influenced by low performance of the model on disease classes, so macro average scores were lower than micro averaged. Class 1 was the most difficult. It had a low recall and high confusion with class 0 and also class 2. And moderate diabetic retinopathy also was misclassified in 90% of the cases as no disease at all. Binary classification, good specificity, but good low sensitivity, in large part due to many mild and moderate DR images being misclassified. Decreasing subsets for CIFAR-10, training curves were stable again, performance increased predictably, overfitting was less pronounced for the smaller training subsets. For diabetic retinopathy, more instability again, performance starts to degrade after 20 epoch. There is more overfitting on all subsets. Performance of models trained with data down to 40% were very similar. This raises the question if there's too much data and not enough variety, or if the information that the model, there is information that a model is not able to capture. Continual learning experiments, all 10% rehearsal methods perform similarly for CIFAR-10, better than naive fine-tuning. They were comparable to static 20%, and only cumulative rehearsal reached static 80% performance, or close to it. For the diabetic retinopathy, somewhat similar image. Random sampling and certainty sampling were better than naive. Loss-based sampling diverged, however, after 15 epoch. Training times, this is how they go up with training data size, almost linearly. There is also overhead due to tracking and calculating training and validation metrics added 3,100 seconds of additional training time. And discussion. There is a low degree of standardization between performance metrics in literature. While the best model in this thesis, static 80%, is still modest. Binary specificity is good. Binary recall is low. Class recall is very low, and accuracy and Q kappa are fair. However, it should be noted that some of these impressive metrics were evaluated on a different dataset, and Q kappa is very likely volatile when it compares to comparing datasets with different data distributions. Static 80% had very low sensitivity for mild DR. Moderate DR was also misclassified often. This is problematic in a clinical setting if 1/4 of the advanced cases may be misclassified. However, this difficulty was well documented in literature. In practice, of course, the model is likely unsuitable for clinical use, but it's at least not likely to yield many false positives. But this was anticipated. The purpose was to provide a theoretical upper bound for a threshold for the CL experiments. For continual learning, models trained in a static setting on 80 and 60% greatly outperformed naive and 10% rehearsals for both tasks. Effective training, I should mention, there was much higher for static 80% because fine-tuning for the continual learning experiments, I trained each subset for a limited amount of epochs, so it's likely that performance can increase beyond the 200 total epochs. For the first subset, I tracked performance backwards as the model continued to learn from other datasets. Performance dropped after model started training on a separate subset due to catastrophic forgetting, but it eventually recovers and overtakes the previous peak. And it improves even under naive conditions if the underlying distribution does not change. Same for diabetic retinopathy, but more unstable. For continual learning, I explored if the 10% rehearsal methods can come close to the cumulative experiment. In my results, they don't. They perform better than naive, but not that close to cumulative. Uncertainty sampling, however, for DR performed much better than all other rehearsal methods, but cumulative. And there is a small computational advantage that should be noted, like the rehearsal methods performed similarly to static 20%, but they were 3 to 4 times less computationally intensive. About uncertainty sampling patterns, I evaluated the images that were selected by the uncertainty sampler and noticed that the most uncertain images tended to have a very different distribution than the most certain labels. Subjectively, I think they were lower quality. They displayed poor lighting conditions, edge warping, blur, and acquisition artifacts. This is the difference. These are the differences in distributions. The uncertain labels sampled by the sampler tended to focus more on the underrepresented labels, and the more certain images were mostly from class 0. Um, Due to the unbalanced nature of the data set, was reflected in the wrong prediction for the minority classes. You can see here they follow closely the prior distribution of those classes themselves. And this, combined with the tendency of the random sampler to select fewer classes that exhibited lower recall, it means that increased sampling of the disease classes and more augmentations are likely to increase performance in both static and continual learning scenarios. About training times, eye examination takes 5 to 10 minutes to perform. Ophthalmology clinics typically perform 50 to 100 examinations each day. And since 25 pre-processed images can be computed each second on a mid-range view, it means hardware concerns would likely not be a limiting factor in devising strategies, even locally. For future work, there is a limitation due to hardware constraint that I could not validate these results properly. We would require at least 5-fold cross-validation. For the static benchmark, the kappa, although it fell behind the state of the art, it's optimistic nevertheless, as many improvements are possible. I just didn't have time to implement all of them. We could do more data, add more data, explore other data sets, do more data pre-processing, increase sampling, data augmentations, regularization, bigger models, ensembling, loss functions, and so on. For the continual learning setting, we can further explore the backwards task with an actual validation set. Although we saw that the CL learning curves did not plateau, so we should explore how much more they can learn. There's a limitation in the sense that the subsets were sampled from the same distribution, so catastrophic forgetting was not tested robustly. We should explore how shifts in distribution affect model performance due to scanner acquisition properties, shifts in patient distribution or class distribution. And although it's reasonable to expect obtaining consent for 10% of the data, if we want to go further, this might be difficult. We might need to explore pseudo-rehearsal methods or all other kinds of continual learning methods that prevent catastrophic forgetting. The sampling that I did with ensembling is computationally inefficient. To train these models at test time, we should include the Monte Carlo dropout uncertainty sampling, where we activate dropout layers in the same network and get a spread, a distribution of the predictions. The static 80% model would need to be improved before deploying it. Naturally, a lot more guarantees for continual learning settings would need to be established before we even think about deploying it in a clinical setting. It still offers some advantages: flexibility, computational speed, and memory size data acquisition. And for the conclusions, Static 80% performs well overall, but struggles with mild and moderate DR detection. Performance could be improved with many avenues. Continual learning offers efficiency, flexibility, but we need further testing for catastrophic forgetting. Uncertainty-based sampling improves classification and performance, but future research should examine Monte Carlo dropout uncertainty methods. And the robust static model first must be validated before introducing continual learning methods in clinical setting. And this was my presentation. Thank you very much.